Hello doctors. Today let's talk about some diseases of the anterior pituitary. We have the anterior pituitary and the posterior pituitary, but in this video we will mainly talk about the diseases that are from the anterior pituitary. Normally in the physiology videos we would have seen that the hypothalamus produces some hormones that stimulates the pituitary and makes the pituitary to release other hormones, and those hormones would go to the organs and show their effect. This is how the normal physiology occurs. To see in detail, we have the CRH, that is the corticotropin releasing hormone from the hypothalamus, which stimulates the pituitary to produce adrenocorticotrophic hormone. And then we have the thyrotropin releasing hormone, which stimulates the pituitary to produce TSH. We also have the gonadotropin releasing hormones that stimulates the pituitary to produce LH and FSH. Just like that, in a different manner, we have the dopamine coming from the hypothalamus, which inhibits the prolactin. Normally there is prolactin release from the pituitary. That release is controlled by the dopamine. The dopamine constantly inhibits the release of prolactin. So if there is decrease in dopamine, there would be more of prolactin. Then we have the growth hormone releasing hormone, which stimulates the growth hormone. Just like that, we have growth hormone inhibiting hormone, or the somatostatin, that inhibits the growth hormone. Normally these are the things coming from the pituitary. If there is a pituitary tumor regarding any one of these producing cells, for example ACTH producing cell tumor in the pituitary would secrete more ACTH. Growth hormone secreting tumor in the pituitary would secrete more growth hormone. Just like that, if there is a small tumor in pituitary, in the prolactin producing cells there would be more release of prolactin. In this video I will just talk mainly about the things that would be useful later. Now the growth hormone does not directly go to the organs and shows its effect. It goes to the liver and stimulates the liver to release IGF, that is insulin like growth factor 1. This IGF-1 then goes to the organs and shows the effect. This is how growth hormone works. There is also another work of the growth hormone. Growth hormone is just like glucagon. It is just counter-regulatory to insulin. If the insulin decreases the glucose, the growth hormone would increase the glucose by suppressing the insulin. That is, growth hormone acts opposite to insulin. So if our body is in need of glucose, then growth hormone would rise, causing more glucose to be produced. Now let's see about the diseases of the anterior pituitary. Mainly we have three diseases, that is hyperprolactinemia, acromegaly, and hypopituitarism. Hyperprolactinemia. What are the causes? Even just a simple stress can cause more release of prolactin. And pregnancy, we all know that after the pregnancy there is lots of prolactin release, which is used for the milk production. But even during the pregnancy, some patients can have increase in the level of prolactin. The next cause would be a nipple stimulation causing galactorrhea. And we also have prolactinomas, that is prolactin secreting tumors in the pituitary. The other causes are dopamine blocking drugs. Just now we saw that dopamine inhibits prolactin. So if you are inhibiting the dopamine itself, then there would be no effect of dopamine on prolactin. So nothing is there to stop the prolactin release. So there would be more and more of prolactin. H2 blockers like cimetidine can cause hyperprolactinemia, and an important cause is also hypothyroidism. Whenever there is hypothyroidism, we know that the T3 and T4 is low, but the TSH is high. This TSH goes back to the pituitary and may cause increase in prolactin also. That is how hypothyroidism is related with hyperprolactinemia. Now, what are the features seen in hyperprolactinemia? The patient will have amenorrhea. This is because increase in prolactin inhibits the LH and FSH, just like after the pregnancy. After the pregnancy, the mother is usually giving milk and there would be no menstrual cycle. This is because when there is more of prolactin, the LH and FSH would not work. So in the feature of hyperprolactinemia is amenorrhea and galactorrhea, that is milk secretion. The patient will also have infertility because the LH and FSH gonadotropin hormones are not working. The patient will have decreased libido and the patient would have hemianopia, that is bitemporal hemianopia. This is because just near the pituitary gland, above of it is the optic chiasm. If there is a tumor in pituitary gland, that can compress the optic chiasm, causing bitemporal hemianopia. That is, the lateral vision of the patient is not seen. So the patient only can see what is there in the forward, cannot see what is in the right or in the left. Now to diagnose this, first we have to exclude the common causes, like check for pregnancy, check for stress, and ask history about dopamine blocking drugs, H2 blockers, and check for thyroid hormones. After excluding the causes, if the patient is still having increase in prolactin, which we find out in a serum prolactin level, then the diagnosis would be confirmed. Then we do MRI brain to see if there is any tumor and localize the tumor. This is about hyperprolactinemia. Next, let's see about acromegaly. Acromegaly is usually caused by a pituitary adenoma which secretes growth hormone. Now, if this adenoma occurs in a patient who has not yet attained his or her puberty, that would be called as gigantism. Once the puberty is attained, the growth plates are closed and then only specific parts would enlarge with the growth hormone. That is called as acromegaly. So let's see the features. The patient will have enlarged hands and feet, and prognathism is protruding jaw, macroglasia is big tongue, organomegaly, all the organs will be big, and the patient will have bilateral carpal tunnel syndrome. Now usually unilateral carpal tunnel syndrome is common. That may be due to some work related issues. But bilateral carpal tunnel, you have to mainly think about acromegaly and hypothyroidism. Now patients who have acromegaly can develop diabetes and colon cancer and colon polyps, and the patient would die mainly of heart failure because the heart is unable to pump for the organs which are large. That is heart failure. Now to diagnose this, we have to check for the levels of IGF-1, that is the somatomedin. Now previously we saw that the growth hormone doesn't directly go to the organs and exert its effect. It first goes to the liver, then causes IGF-1 to be released. So we measure IGF-1. Also growth hormone is not continuously released. it is released in a pulsatile manner. So there is no proper time to check the growth hormone, because sometimes it may be releasing more, sometimes it will be releasing less. So instead of that, we try to measure IGF-1, that is somatomedin levels. Now let's talk about growth hormone suppression test. Now listen this carefully. As I said before, the growth hormone increases the level of glucose. So what do we do here is, we give a patient a glucose load, that is, we give them glucose. What should happen? That is, when there is high amount of glucose, there is no need for growth hormone to increase the glucose. When we give glucose, the job here is for the insulin to reduce the amount of glucose. So what happens in a normal patient is that when you give when you give glucose, the growth hormone level should decrease, because there is no need of growth hormone now, because the glucose is already high. But what happens in a patient with acromegaly is that even after giving glucose, the growth hormone of that patient is still high, which is suggestive of acromegaly. So the patient's glucose is always high due to high levels of growth hormone. That is why these patients would develop diabetes. Now, after confirming the diagnosis of acromegaly, we do MRI brain just to locate the lesion. Now, next see about hypopituitarism. The causes of hypopituitarism is TB or sarcoidosis, which can infiltrate the pituitary gland and destroy the pituitary gland, causing all hormones to be decreased, or a craniopharyngioma that is usually seen in children, which is a remnant of Rathke's pouch, can cause hypopituitarism. Pituitary adenoma or pituitary apoplexy, that is pituitary apoplexy is when there is a pituitary adenoma not treated properly. There can be blood breaking or blood clot forming, that is destroying the pituitary, causing hemorrhage. Or Sheehan syndrome, that is usually seen postpartum, that is ischemic necrosis of the pituitary. Or radiation causing damage to pituitary. The patient might have had some neck surgery or head surgery for which he or she might have needed radiation, and that could destroy the pituitary. Whenever the pituitary is destroyed, the first hormones to be lost are growth hormone, luteinizing hormone, and follicle stimulating hormone. And lastly, the ACTH is lost. If you see here, the ACTH is most needed in our body, so that will be lost at last. So whenever you suspect hypopituitarism, you have to check for growth hormone or LH, FSH, so that you can make a diagnosis. But if you are checking for ACTH, that may be low or not, because ACTH usually low after a few days or months, that is becomes low at last. So to diagnose yearly, you have to check for the hormones that are lost yearly. Then we also have the causative symptoms, that is, if you have TB, you would have TB symptoms or sarcoidosis symptoms, like that. For the diagnosis, we do a growth hormone stimulation test, that is just the opposite of the suppression test. Now in this case, the growth hormone is very low. So what do we do is, we give the patient insulin. Normally when you give insulin, the insulin eats all the glucose. So now it is the job of growth hormone to raise the glucose. But in a patient with hypopituitarism, even after giving insulin, the growth hormone level would be still low because the patient is having hypopituitarism. Even though the patient's body is not having enough glucose, the growth hormone, since it is not present at sufficient amount, cannot raise the amount of glucose. By this we can diagnose the hypopituitarism. Now for the treatment, if you see, in the hyperprolactinemia, the treatment is dopamine agonist. If you are giving dopamine, it would directly block the prolactin. So we give drugs like bromocriptine or cabergoline, that is dopamine agonist. This is what is done initially. Then we choose for surgical or radiotherapy. For acromegaly, the treatment is octreotide, that is the somatostatin, growth hormone inhibiting hormone, or pegvisomant, which blocks growth hormone receptors, surgical excision or radiotherapy. For hypopituitarism, we just replace the hormones that are lost and treat the cause. That's all, doctors. Thank you.